Good evening, friends. So, another one of our expert series in 2023. You may be wondering, why am I giving so much stress to kidney? Because I'm sure you all have realized that more and more of our patients, hypertensives, diabetics, even without hypertension, diabetes, are getting raised creatinine and reduced eGFR readings. All of them are in the range of chronic kidney disease. And if we do not handle them well, they're going to be landing up with dialysis or transplant, which most of our patients cannot afford. Either they have low money, no money, or they have no support system. In this year only, I have spoken twice about kidney, and today we have an expert with us, dashing Dr. Sudhiranjan Dash, MBBS, MD Medicine, DNB Nephrology, MNAMS, Postdoctoral Clinical Fellowship Nephrology, University of Toronto, Canada, Hypertension Specialist, member American Society of Hypertension, New York, SCE Nephrology, UK, ESE Nephrology, EDTA, Europe, Diploma in Hospital Management, and Advanced Certification in Digital Imaging. He's been an ex-associate professor of JJ Group of Hospitals, ex-senior consultant and HOD Jaslok Hospital, and now senior consultant nephrologist, HOD Academics, Department of Nephrology, Sir H.N. Reliance Foundation Hospital and Research Center. I personally know Dr. Dash for almost last 10-15 years, and I am privy to his expertise. So when I thought of calling an expert to talk of how we should manage CKD, because there are 5 stages. Last is end-stage renal disease, which is dialysis and transplant, and there is no active treatment between stage 1 to stage 4. It is just monitoring, and we are better equipped. Of course, patients can go to nephrologist, but you need to see the patient repeatedly, maybe once in 2 weeks, once in a month, to make sure the risk factors are controlled. So over to Dr. Dash. Dr. Dash, please take over the presentation.
Yes, sir. Thank you so much. Thank you so much, sir, for your kind introduction. And it is a privilege that you have asked me to talk about a chronic kidney disease, which is common and quite causing more damage to the population rather than a infective etiology. It is called as slow death in when you are talking about the WHO definition. Chronic kidney disease is a non-communicable disease which causes much of morbidity and mortality. And it is ranked after probably the next one after the cancer itself. But if you see the death due to cancer is much more, you can say, in a short span of time it happens, whereas chronic kidney disease patients face a lot of difficulties. I will not take much time. I will share my presentation here. And thank you all for participating in this webinar. Sir, may I share the slide now, sir?
Yeah, please start. Please start.
Okay. Can everybody see the slide? What I have shared?
Yes, sir.
Okay, thank you so much. So, first, let me jot out how I will be outlining my topic. That will be basically by introducing the subject, which will be in a nutshell, since I know that that is a time constraints we have. Then what is CKD? And everybody knows about CKD, but by definition, what we should be aiming at and define CKD. Then what are the fallacies of the creatinine as a marker, and what is calculated GFR, and how to define a at-risk population. Then we'll discuss about some of the renal protection and why it is essential, whether we are actually doing a harm or we are doing benefit for the patient, and why it is done. Third one is the primary prevention and the secondary prevention. And I will be much more emphatic on specific scenarios which I am daily facing day to day, which I can share with you, and certain things I wanted to share with you, how to take precautions, how to advise and follow during the process of seeing any CKD patient. Then we'll be seeing certain scenarios regarding the delaying the progression of CKD population, and concluding remarks. So this will be my outline. This slide is not moving. Yeah. So what is chronic kidney disease? It is a very simple, everybody knows it, and you are much more aware about it, that we call it a CKD when we are defining the GFR to be lower than the normal values if it remains there for more than 3 months. What is meaning by lower than the normal value? So what is low in normal population when they age? Obviously, when you age, all your organs of your body and your exterior, everything ages with time, and that is unpreventable. Basically, you have to age with time, and with that, whenever the aging process happens, it causes some changes in your organs, internal organs, and that obviously will be reflected on the in the outcome. However, that aging process and causing the organ dysfunction is termed as a natural progression. So what we define is basically is GFR. If you take into account the glomerular filtration rate, if it is 100% when you are young, after 40 years of age, it declines with aging. And when the decline of GFR normally happens around 10 ml in 10 years, or 1 ml per year. So let us speak about a person who is 60 years of age. So natural decline will be 100 minus 60 will be 40. So that is basically 40 plus 20. So it is basically 40 plus 20 is 60. So 20 ml of GFR decline you expect. So 100 minus 20 will be 80 ml of GFR is the natural decline. So if it is below that natural decline, then you call it as chronic kidney disease if it persists for more than 3 months. That is one definition which has been highlighted everywhere. But what are the additional points we have to remember is that this defines that if there is a temporary rise in creatinine, that doesn't mean that the patient is having chronic kidney disease, or one-time estimation is not valid. So we have to show subsequently that it has to happen, and progressive deterioration is happening over 3 months, and the creatinine is rising for 3 months or more, or the GFR, whatever. Then another point to remember is basically radiological and histopathological evidence, or a nuclear scan evidence. This has been added recently in last 20 years. Why? Now it has been seen that a patient, let us say that a patient comes to you with diabetes, and the GFR you have calculated is 120 ml. Okay, so however, the patient is having persistent proteinuria of ACR, ACR of more than 200 for almost 3 months. So this patient, although the GFR is normal or higher, you can say that the patient is having chronic kidney disease due to the albuminuria excretion. Likewise, in radiologically, if there is a contracted kidney, you can say that, or if there is any scarred kidneys, you can say that the patient is having chronic kidney disease. But it will be established with what will be the GFR and proteinuria along with that. Histopathologically, when we do a kidney biopsy, we see tubular damage, interstitial fibrosis could be, which are irreversible. Then if it is like that, then also you have to define, although the GFR might be just below normal level according to the natural progression, but still we will tell that the patient is having CKD. When we talk about transplantation, we are talking about a person who has got a new kidney, and if the kidney function or the GFR remains around 50 or 60 ml per minute, 50 ml per minute, then also you have to tell that the patient is having CKD T. In that scenario, we tell it as CKD T, T for transplantation. So this is how it has to be defined. Then coming to the serum creatinine concentration, you know that there are so much variable factors which are there. So these are the gist of variable factors. Which is more essential to know is the muscle mass of the patient, from where the kidney, the creatinine is generated, and obviously the dietary pattern and the gender of the patient and age of the patient. So older the age, muscle mass will be low, so the creatinine values will be lower in those group of patients. So another thing is the medications which can actually cause interactions in the assay of during the creatinine estimation. So like if right now I think everybody does a enzymatic reaction. So enzymatic reaction doesn't pick up this one, but if those older generation assays were used, then you can have interference from ketosis, let us say in any type of ketosis, or if there are certain group of cephalosporins used, then you can have increased creatinine value in those group of patients, although the GFR will be something different. So fallaciously high GFR, low GFR can be read from the creatinine. So we know that the creatinine is not a good marker. So how to define the GFR in that scenario? We calculate the GFR, or we call it as eGFR, that is the estimated GFR. So estimated GFR advantage is we can use it during the day-to-day scenario. We can get the creatinine value, and there are certain applications in your software are available in mobile as well as in the computer, where you can put the numbers and find out how much is the eGFR. And often earlier we used to use Cockcroft-Gault formula, which has been nowadays discarded due to certain fallacies in it. And nowadays more of we are using MDRD formula or CKD EPI formula. So the CKD EPI formula is much more precise in estimating the GFR rather than MDRD formula. There are lots of theories on that. I will not discuss about that during this session. However, you have to see that what are the equations for the CKD EPI formula. There are two equations for the CKD EPI formula. One is by the serum creatinine level. The other one is by serum creatinine and cystatin C level. Cystatin C also is a biomarker for identifying early cases of decline in GFR. It is basically increases much more higher when the earlier when the GFR declines rather than the creatinine, since we know that the creatinine can only increase if the 50% of your GFR declines. So between 50 to 100%, we don't have much of biomarkers. Here the help comes from the cystatin C. And this cystatin C and creatinine, if you combine together, then it gives approximate a good GFR, estimation of GFR. So the markers I have told you about, these are some of the markers which can be used, and the eGFR calculation, which has been already, I think, every big laboratories or NABH accredited laboratories are doing nowadays. They are giving a serum creatinine value along with the eGFR value calculated accordingly. So then comes, you know about the, already Dr. Asrani sir has told about what are the major contributors towards the CKD, diabetes, hypertension being the most common diseases which contribute towards CKD. There are others also, inherited disorders, glomerular diseases, connective tissue disorders, obstructive uropathy is another one, and there are some miscellaneous conditions. We know about the uremic symptoms, syndromes. Basically, when the kidney function declines, we know that there will be a fluid and electrolyte imbalance. It gives much of trouble for the cardiovascular pulmonary circuit. In the fluid overload or the hypertension is much more commoner in those group of patients. Then you can have central nervous system. Every system of your body will be affected due to the uremic toxins. And obviously, those will be manifested at certain period of time. So what we need to do is basically we identify those if early in the early and try to manage these symptoms so that the patient will be in a better state. So now coming to the proteinuria and the GFR decline. So why we are much more worried about the proteinuria part? If the patient is losing protein in the urine, whether it is causing any harm to the patient. So this study, which has been depicted here, it gives you an idea that proteinuria alone, if the GFR also doesn't is normal at the initial period, proteinuria alone can cause decline in GFR with due course of time. So higher the proteinuria, you can see that the decline in GFR rapidly happens over time. So almost you can say that if the proteinuria is more than 3 grams or nephrotic range proteinuria, then the GFR decline happens around 10 ml per minute per year, which would be 1 ml per minute per year after 40 years. It happens very rapidly, around 10 to 20 ml per minute per year. So in that scenario, if you don't prevent or address to the issue of proteinuria, then obviously you will be in trouble. Then what are the recommendations for the proteinuria and albuminuria estimation? So the recommended one, this is the KDOQI guidelines, that is the kidney dialysis quality index guidelines. They say that you have to do at least recommended in the first visit. Then subsequently in the follow-up visit, if you want to do at 1 month interval or 3 months interval, you can do a non-recommended ones, but be sure that at least in 6 months time you have to do the recommended estimation. So what are the recommended estimation? The recommended one is 24 hours urinary creatine protein estimation and the creatinine estimation. So always the creatinine has to be measurement has to be done along with the protein estimation to know what is the adequacy of collection. If it is not there, then probably we might underestimate or overestimate the proteinuria. So that's why it is better idea to do a 24 hours urinary protein estimation along with creatinine. Then the ratio overnight sample, which is the fast morning void sample, has to be used in some of the patients to adequately assess in the first visit of EOS or the second visit of EOS to know whether your intervention has actually affected it or not. And non-recommended ones, one is the dipstick. It only gives you a qualitative idea, not a quantitative idea. Spot piece protein creatinine ratio gives you some amount of idea, but it is an inaccurate method. So let us talk about better to have a fast morning void and get a 24 hours urinary protein estimation. Much that has to be done at intervals. Then what are the problems with the CKD? Why we are worried about CKD? We have seen that the patient with CKD, they have traditional risk factors and non-traditional risk factors. And invariably, you will say that the hospitalization rate increases when the GFR declines in those group of patients. And it is the best way will be to address the issue of traditional risk factors and as well as non-traditional, especially the modifiable and non-modifiable risk factors. The modifiable risk factors are like smoking and physical activity. All those are modifiable risk factors, plus all other things like blood pressure control, albuminuria control, and the anemia management, all other things which I will be describing later. Malnutrition is one of them. And then non-modifiable risk factors are obviously the gender, the sex, the gender, and also age, and inheritance. So those we cannot modify. However, we can address those issues in those group of patients who are about or at risk individuals. So what is the CKD risk? We know that, and I have not defined, it has been already, I think everybody knows about the stages of CKD. So we grade the stages according to the CKD stage 1 to stage 5. And these are the stages you can see. CKD stage 1 to stage 5. And less than 15 is the stage 5. So why we are so much worried about CKD? You can see here the cardiovascular risk, deaths, in or mortality and the morbidity along with the CKD progression. You can see almost 14 point odds ratio of almost 14.4, hazard ratio of around 14.4, and 36 of hazard ratio of around 36 in cases of end-stage renal disease with cardiovascular risk. So people who are dying of cardiovascular risk factors in chronic kidney disease, that's much more rather than dying of chronic kidney disease itself. So this is the same slide. Now, this is a very important slide for you to remember. So this is a heat map, you can say, and it is available online. So that's why I just put it. You can put the number, how much is the albumin creatinine ratio and the GFR, eGFR, whatever you have calculated, and put the number. The red one is the most dangerous one since they have all-cause mortality as well as the cardiovascular mortality. So that's why those group of patients should be segregated and to be treated separately. Whereas it is not so that we will not be addressing the issue to the other people, since these are basically people who can be benefited from primary and secondary prevention. So here, if the person is in the green zone, you can follow up closely in 3 months to 6 months interval, and see the GFR decline is not happening and the albumin creatinine ratio is not increasing, then you are in a safe zone. So the crux of this slide is basically you can put it in the heat chart and then see over in the follow-up period that whether the patient is progressing or it is static, or you are able to achieve the reversibility. Like in the yellow zone, you can actually, if you give proper attention, give proper medications, then you can revert it from yellow to green. So that will be your achievement. So as Dr. Ashrani said, that prevention is the most important thing, since we in CKD stage 5, we are not having much to offer. We have to do either transplant or dialysis or any form of renal replacement therapy to sustain the patient, and it is much more expensive in our resource limited setting. So prevention is the main key factor, and as a general practitioner, you are much more acquainted with the patient and the family members, and also the convincing power of you will be much more better than a person like a nephrologist, where we interact with the patients at a later period of time, but early in we can devise a plan and then guide you in that direction so that you can have a follow-up closely, and accordingly the patient will be benefited. So now coming to the management of CKD, I'll be giving you certain scenarios. Obviously, everybody knows that blood pressure control is much more important, and as well as the blood sugar control is much more important. And whatever CKD related complications we are facing at that point of time, we should be addressing those issues. So this is a nutshell basically I'm giving you. that the blood pressure should be here. The blood pressure, why I am trying to tell you again and again, is basically a person who is having only hypertension, not having any CKD, then the goal of blood pressure control is something different. Like in sprint trial, you must have known about the sprint trial, which has been recently done in general population with hypertension, but without any target organ damage. There are certain subset of groups which are having target organ damage. Those are also included. But overall, you can say that the blood pressure control in those group of patients are of normal individuals not having target organ damage. The blood pressure control is something different. Whereas in CKD population or those people who are having proteinuria, the target is something different. And whenever we are utilizing the antihypertensive, we prefer certain group of drugs other than the others. Like ACE inhibitors and ARBs, we use much more higher in those group of patients for their benefit itself, for renal protection. Whereas the dose of ACE inhibitors and ARBs or any other antihypertensives are quite different. Let us say that the proteinuria, a patient comes with a CKD with proteinuria with hypertension. Then your blood pressure might be controlled with the drug itself, whatever you have advised. But for the proteinuria, you have to go up in your antihypertensive dose so that the proteinuria reduction will happen. It is not the blood pressure alone. It is the proteinuria reduction also has to be seen in that group of patients. And for that, we sometimes use a supratherapeutic dose in the sense that, let us say, losartan, you can go up to 100 milligram in normal individuals, 100 to 200 milligram. We might have to go up to around 400 milligram for the benefit of the patient for proteinuria reduction. Likewise, the ramipril, when we are using, the normal conventional dose maximum is basically 10 to 20 milligram, whereas we can go up to 40 milligram for better control. But there are certain fallacies to it. You have to closely monitor about that. So, and more than one drug is required along with diuretics, and the best possible glycemic control, by which you avoid the hypoglycemic episodes, that has to be devised. And obviously, the management of bone mineral disease has to be addressed, and management of anemia and acid-base disorders to be addressed as well. So these are some of the recommendations which has been given by the KDOQI guidelines. So first, whenever we are using calcium channel blockers, then use dihydropyridine group of drugs rather than non-dihydropyridine group of drugs. Whereas those, the first line of management should be ACE inhibitors or ARBs. And protein intake also, they have recommendation level 1. Since protein has been, there is a very good example in the sense that the certain, like the Brenner and Rector kidney book you must have seen, the Dr. Brenner has done certain studies on high protein diet in those group of animals and found out that the GFR of the patient increases when you are taking high protein diet. And the GFR is basically how it is increasing. It is due to the increased glomerular capillary pressure. So, and sustained glomerular capillary pressure causes more damage to the kidneys, and that will obviously, with the protein control, you can reduce the decrease in the glomerular pressure. Likewise, other things are also has been described. It has, I think everybody knows that Another one is the phosphorus level, which is the bone mineral disease. So here, the phosphorus level is a directly nephrotoxin, toxic agent. It is a nephrotoxin. So more the phosphorus, it will cause more rapid decline in the GFR. So that's why it is essential that phosphorus has to be controlled. And that's why sometimes if the calcium phosphorus product, which is the calcium in milligram percent and phosphorus in milligram percent, if you multiply those, if it is more than 445, then we say that it is a dangerous level. So you reduce the phosphorus accordingly. And the phosphorus in that scenario, you cannot use the calcium content binding agents. There are two types of phosphate binding agents. One is calcium based, the other one is non-calcium based. So the calcium based phosphorus binders should not be used if the calcium phosphorus product is more than 45. So the problem with that is basically when you use calcium, that gets absorbed with the vitamin D, and it causes precipitation of calcium and phosphorus inside your endothelium in the vasculature, causing more of calcium deposits and causing narrowing of the vessels. So calciphylaxis, that is the newer that is calcific uremic arteriolopathy. That is what the new term is. So another one is the parathyroid hormone level that has to be also intermittently seen. Basically, 6 months interval you have to do the parathyroid hormone level. If the parathyroid hormone level is 2 to 3 times, we are having the recommendation. So if it is more than that, then you bring it down by giving vitamin D. And if it is lower, then you stop vitamin D. So in your prescription, it has to be seen that all patients should not be getting a tailor-made prescription of vitamin D and calcium, since whenever you are seeing the calcium and phosphorus level in your blood, accordingly you decide and also see the parathyroid hormone, then decide what is the proper treatment. And if the calcium level is higher, then use non-calcium based phosphate binders like the cevilamide and the lanthanum. Lanthanum is nowadays not available. It is due to the rarest toxicity, heavy metal toxicity which has been found. And whereas cevilamide is available now with us. There are certain iron binders also which are available, and those iron binders are something different in the sense that they don't get absorbed from the intestine. So iron toxicity also will not happen in those group of patients. Or in case of iron deficiency, also it will not help you. It is selectively, it will be binding with the phosphorus in the intestine and get excreted in the stool. Smoking cessation is a very important thing which has to be told to the patient. And it has been seen that smoking causes more rapid decline in the GFR. And administration of alkali therapy like the bicarbonate, sodium bicarbonate, to maintain your bicarbonate level around 22 to 24. That is the level where you have to give the bicarbonate. It is not only just prescribing the bicarbonate and just one tablet TDS. That is not enough. You have to see that the bicarbonate level has to reach, at least the patient should have 22 milliequivalent per liter of bicarbonate in the blood, so that it will be neutralized. The acid will be neutralized. So these are some of the, what is the importance of early nephrologist intervention? Basically, it has been recommended that nephrologists should be involved when the GFR declines to 30 ml per minute, and subsequently the majority of the patients will be basically followed up in the by the family physicians, and a plan will be made how to go about it, how to benefit the patient. And this is the slide which gives us an idea that early intervention, if you take into account no treatment versus early treatment and the current recommended treatment, then early intervention, you are basically increasing the lifespan of the kidney itself and decreasing the decline in GFR. So this is a scenario based I will discuss now on. That these are some of the real-time things which you will be finding it in your clinical practice. This patient is 60 years old male, diabetes with hypertension on amlodipine. BP is poorly controlled. Creatine was 1.2 milligram percent with normal electrolytes. UPCR is around 1,500 milligram of proteinuria is having. And so we started the patient on telmisartan, thinking that the patient's blood pressure is not controlled and it will help the patient in reducing the proteinuria with the creatinine remaining 1.2. The patient lost to follow-up for 1 month, although we said that the patient should come to our follow-up after 10 days or so. Patient came with feeling unwell. The creatinine went up to 3 milligram percent now with the potassium of 6 and BUN of increasing. So what has happened now in this scenario? So this is the sorry, yeah. So this is the scenario we are facing at this moment, is basically renal autoregulation. When your chronic kidney disease happens, at that point of time, there is a renal autoregulation goes, instead of the mean arterial pressure between 80 to 160, it reduces. So any time type of insult medication you want to use, then either this renal autoregulation gets exaggerated, which can cause decline in GFR. It is due to this phenomenon. If you say what is renal autoregulation in simple statement, is basically whenever the kidney function declines, the kidney itself tries to accommodate to the environment. How it accommodates? It dilates the afferent arteriole, which is there. It is a single glomerulus, which I am showing you right now. So that's why it is called as single nephron GFR. So if you take one glomerulus each and combine together, then the total GFR comes. So it is basically reflective of a single nephron GFR. So SNGFR, how it is maintained? It is maintained by autoregulation, and how it does is afferent arteriolar dilatation and afferent arteriolar constriction. Thereby, it is maintaining the GFR. Since there are loss of nephrons, the remaining nephrons which are viable are causing this GFR to be maintained. So when we are using certain drugs which can cause afferent arteriolar constriction or afferent arteriolar dilatation, then the GFR will decline due to the fall in the glomerular capillary pressure. So that is what happening here. So we have used angiotensin receptor blocker. So we dilated the afferent arteriole. So thereby the GFR got reduced due to decreased glomerular pressure. The same way, so here we have to be sure that this AC inhibitors and ARBs are basically a group of agents which are having, those are like double-edged sword. So you can benefit the patient and one side of your age will be towards you. So you have to be very careful that you should not be injuring yourself or you are harming the patient itself. How? Now you start the medication in a very low dose and start building up and see the decline in GFR. If the creatinine goes up by more than 1.5 times the normal baseline level, or if the potassium goes above 5.5, then you know that this is not the dose which we should be giving. In that scenario, you have to reduce the dose, or you briefly stop the dose, see other things, whether are there any modifiable other risk factors which are there, like infection or something like that, or bad days, like if the patient is having any vomiting or any diarrhea episodes or fever. So in those bad days, you can temporarily stop the ACE inhibitors and ARBs and start having the and then restart it when the patient feels better. So these are some of the patients which can develop acute on chronic renal failure due to the overstretched autoregulation. So what are the predisposing factors where acute deterioration of renal function, GFR can happen? These are the, if those patients were having severe heart disease, liver disease, or nephrotic syndrome, chronic kidney disease, or elderly, more than 80 years old age, and if the patient is dehydrated. So in those group of patients, if you give ACE inhibitors and ARBs or NSAIDs, then there will be a acute deterioration of renal function, and that can cause rise in creatinine, decline in GFR, and hyperkalemia also can happen. And the NSAIDs also act like that. It causes the prostacyclin, which has the substance which dilates the afferent arteriole. If you block that by giving NSAIDs, then it causes decrease in flow, blood flow to the single nephrons, and that will obviously cause decline in GFR. This is another scenario, scenario 2, where a patient was hypertensive, started on olmesartan, hydrochlorothiazide, creatinine of 1.3, and the patient had some soft tissue trauma. He was given painkillers, diclofenac and paracetamol, and the creatinine went up to 4.5 milligram and potassium of 6 milligram. 6 milliequivalents. It is due to the same thing that afferent arteriolar autoregulation was failed. So this is the third scenario, which is basically the patient was a diabetic, 45 kilos with hypertensive on ARBs, smoker. He developed angina. Creatinine was around 1.3 with potassium of 5. And the patient was subjected for angiography. And on 4th to 5th day, patient had oliguria, lethargy, and the creatinine went up. So these are some of the contrast nephropathy type of scenario where you will see. And what are the risk factors for contrast nephropathy? This chronic kidney disease, if the patient is having any, like the similar things, basically heart failure and volume depletion, and if the patient is having a nephrotic syndrome, multiple myeloma, diabetes with nephropathy, and low albumin state, chronic liver disease, all those are basically predisposed to contrast nephropathy easily. So here, I think this slide is basically for the morbidity and mortality in cases of renal replacement therapy. You can see that the congestive heart, CVA, the cerebrovascular accidents and the congestive heart failure are much more commoner in those group of patients where the patient are on renal replacement therapy rather than any other. So morbidity, mortality happens due to heart related issues and the central nervous system related issues rather than the dialysis modalities itself or the transplant itself. So this is already done. This I think already been described. So what are the strategies to delay the progression? The dietary protein intake, which is actually, there are two ways by which you can ask the patient to reduce the dietary protein. You have to first calculate how much is the protein intake of the patient. Arbitrarily, we cannot say that the patient should reduce the protein intake, since the ICMR studies in different parts of our country has been seen that in western part and as well as in northern part of the country, they have their protein intake is much more lower than the eastern and southern part of the country. And the recommendation of protein in those group of this population is 0.6 grams, whereas the intake in those group of patients has been seen that is around 0.3 to 0.4 grams per kg per day. So we have to first find out whether the patient is actually taking high protein diet. Since all the recommendation of protein intake has been from the Western literature, and they eat much of non-vegetarian diet, their high biological value non-vegetarian diet of the tune of around 1.2 to 1.5 grams per kg per day. There, obviously, the protein restriction will benefit. Whereas if we do much more rigorously the protein restriction in our group of patients without knowing what is their protein consumption, then they can go into protein energy malnutrition, which is much more difficult to address rather than just decline in GFR. So that's why my suggestion would be to all of you will be to first know how much is the protein intake. And many of us are basically vegetarian food dietary pattern has been seen. So if your population sees that is vegetarian, then please be careful about protein restriction in those group of patients. It is better to allow them, give some protein like the dal and other things. But dairy products, sometimes if you see that the phosphate level is much more higher, then you can restrict the dairy products. Salt intake, as we know that it is a very crucial pathway for BP control as well as for the indirectly in the GFR decline. So salt also is important in the sense that if you give normal to high salt to the patient, then the antihypertensive will not work effectively. Especially so ACE inhibitors and ARBs, which are the main agents which you will be using to delay the progression. So that's why salt intake is very essential, and avoid any salt substitutes in the form of brown salt or any low sodium Lona type of salt, which are basically potassium chloride and which could be detrimental to the patient. Physical activity is very essential. for the patients, allow them to do as much as possible the physical activity to their satisfaction. Smoking cessation, as I said, is very essential. And whenever you are seeing a patient, maybe in 6 months' time, do an anthropometry to see whether the patient is having any protein energy malnutrition or not. So these are the modifiable risk factors with the lifestyle modification, with the weight reduction, diet plan, and dietary sodium restriction, physical activity, and alcohol reduction in the alcohol consumption. You can see that there are variable response of reduction of blood pressure. Then coming to anemia management, most of the time you will see that chronic kidney disease is having normocytic normochromic anemia. But in our population, we have seen iron deficiency state quite often along with the anemia itself. So replenish the iron before starting the erythropoietin. And different studies has been there to see that the beneficial effect of increasing the hemoglobin in delaying the progression as well as increasing the quality of life for those group of patients. However, we have to be very careful about hemoglobin target in different like COAT study, CREATE study, and TREAT study. We have seen that higher the target number, the like if it is more than 12, then it causes more of CV related side effects like cardiovascular as well as cerebrovascular events. And in one of the study, it has been seen that the chances of cancer, if it is there, then there is an increased chance of faster rate of progression of the cancer in those group of patients where the erythropoietin stimulating agents were used. So we have to be sure about it before starting it in those group of patients who are having cancer. Then controlling the lipid, if the patient is already in CKD stage 4, stage 5, then lipid lowering, although it might be having some effect, but very better effect will not find in those group of patients. I think most important is basically lipid lowering in the early stages of CKD, where the CKD stage 1 to stage 3, it gives you much more better result. But when it crosses the CKD stage 4 and stage 5, then it is already burnt. We have burnt our fingers. So tight lipid control is not at all recommended in those group of patients. So this is basically how to, if the patient is having pre-renal, acute on chronic renal failure, then what will be your recommendation of fluid? Ringer lactate or isotonic saline. It has been recommended that rather than ringer lactate, you should use a acetate-based solution. Why? Now, the acetate is basically gets converted to lactate, bicarbonate by the muscle, whereas lactate is basically metabolized by the liver to convert to get bicarbonate. So in those group of patients where the chronic liver disease is there, so don't use any ringer lactate. Or if the patient is in shock with severe lactic acidosis, don't use lactate in that scenario. Rather than use plasmalite or cabilite, which are basically acetate-based solutions. So this is the figure which says that hypovolemia and hypervolemia both are detrimental in management of CKD patients with cardiovascular complications. So this is a very new scenario which I faced recently. Oral antacids are not benign. Basically, that is a lady with Parsi lady who presented with forgetfulness worsening with in next few weeks to drowsiness, disoriented state, and refractory anemia. In spite of giving adequate amount of erythropoietin, there is no blood loss from the GI tract. She was getting adequate dialysis, 3 times a week dialysis, and hemodialysis adequacy is achieved. Whereas the patient is not improving with that also, and the patient later on these are the blood works. Hemoglobin is low with microcytic anemia, although the iron studies showed that it is more of increased iron store. And there is a calcium which is hypocalcemic, phosphorus also within normal limits, and PTH is low. CT scan brain is not much, minimal brain atrophy, and there is a pacemaker in place, so MRI work could not be done. And this creatinine of 5.8 indicates that the patient is properly dialyzed. All other parameters to search for any blood loss or hemolysis were negative. On repeated inquiry, the relatives said a significant history. The patient went for the gastroenterologist before dialysis for complaints of nausea and occasional vomiting, and he was started on PPI and along with that sucralfate. And she continued to take this PPI and sucralfate, and later on we saw that the patient during this year we sent for the heavy metals, and we saw that the patient was having aluminum toxicity. It is basically sucralfate which contains the aluminum as a buffer inside. So in normal individuals, it gets excreted out by the kidneys, whereas in chronic kidney disease patients, this aluminum gets accumulated and it causes toxicity, and it causes anemia, bone disease, as well as dementia. So this has happened in this scenario. So he's subjected the patient with DFO challenge, and it turned out to be positive for aluminum. And later on, we started in giving the desferal, and the patient recovered his senses. So this is a scenario. The other one is, another scenario is like this. The patient is a sub-inspector in Maharashtra Police and was feeling unwell, non-diabetic, only hypertensive, was on Amlobhas 80. Creatine was around 1.6 milligram percent when he came to show me at that point of time. And due to arbitrary food intake, he was prescribed omeprazole for a month, but he continued to take it for almost few months, almost 6 months. The creatinine fluctuated between 2 to 1.8 milligram percent. Blood pressure remained normal. There was no target organ damage. However, urine showed 1+ protein and pus cells 10 to 12, and nitrates are negative. Leukocyte esterase was also negative. Urine culture didn't show any sign of infection. So what I did was stopping the proton pump inhibitor, then asked her to take famotidine instead. And then after a week, when he came back, at that point of time, the creatine was 1.28 milligram percent from 1.8 milligram percent. And the creatinine later on, after 3 weeks, came down to 0.8 milligram percent. So the most common agent which we could find in causing acute interstitial nephritis is PPI and fluoroquinolones. So these are some of the drugs which has to be not to be used, or if you want to use it, please follow up closely. since acute deterioration of kidney function can happen, and these are all reversible things. And acute interstitial nephritis, if it progresses, then it changes to chronic interstitial nephritis, and it can cause progressive chronic kidney disease. So in conclusion, renal protection is essential. Prevention is always better than cure and reduce the burden to the society at large. Primary as well as secondary prevention should be advocated, and family physician participation is a most valuable thing in achieving the goal. And combinedly, if we can make together the efforts, family physician along with the nephrologist, then it maximizes the effect. And this obviously will be the theme for the kidney health for all for the future in directions. So this is a basically take home message will be to identify the problem early and intervene, and see that there is multidisciplinary team has to be introduced. Minimize the use of AC inhibitors, NSAIDs, and whenever you are using any drugs, kindly see that there is no nephrotoxic agents, and especially so that whether the patient is taking it rather than prescribing the patient inadvertently they use Ayurvedic medication which can cause heavy metal toxicity. And sucralfate also should not be used more than 15 days. And since in chronic kidney disease, there is a chance that the patient will be having aluminum toxicity. You should use rationally AC inhibitors, ARBs, and you closely watch for the complications. And always calculate the proteinuria, how much is the proteinuria and the eGFR at intervals, and use that heat chart and plot it over there. Then you can know that what is the improvement in the patient status over time. Thank you so much for the patient listening. Sir, up to you. Asrani sir. Hello.
Thank you, Dr. Dash. There are some questions, most of which you already covered.
Yes,
but,
sir.
Some specific queries have been given.
Yes, sir.
Like, normal diastolic and high systolic, can that also lead to CKD?
Yeah, very good question, sir. Very good question. Actually, this is a initial period when we were actually students. Probably you must be practicing at the early phase of yours. At that point of time, systolic hypertension was not to be treated. That was the guideline earlier. But there are certain trials like CIST Euro trial, CIST China trial, and HIVET trial. So those trials have said in affirmation that systolic hypertension also needs to be treated since they have the potential to cause target organ damage. It is basically those group of patients where beyond 60 years of age, where you will see that the pulse pressure will be high. The widening of pulse pressure indicates that there is a rigid arteries. That's why the diastole has fallen. But the systolic blood pressure has to be also targeted. Many of the times in those group of patients, when we do give ACE inhibitors and ARBs, then the diastolic pressure, if it is 80, it goes down to around 60 or something like that. The systolic blood pressure remains higher, around 160, 170 kind of thing. So then there is a confusion whether we should be causing more harm in those group of patients. But it has been seen that you should be reasonable of reducing the blood pressure of to the tune of 130 to 140 in that group of patients. And in recently, the sprint trial also says that target the blood pressure of around 140 if there is the patient is only having systolic hypertension, between 140 to 150. Since the auto-regulation, what I described was applicable for brain as well as for the kidneys as well.
Thank you, sir. Safety of teneligliptine, metformin, and telmisartan in CKD.
Telmisartan, I have said, na sir, these are some of the our fast agents which has to be used for nephroprotection, AC inhibitors and ARBs.
No, but if the creatinine goes above 3, can we still continue?
Sir, it depends upon how frequently you are monitoring. If you say that the patient is following up with you closely, and like certain nephrologists, old nephrologists, they have a person who visits they have what they did was basically they took up a trial of taking one village, and the person from his care, person itself visited the community and checked the blood pressure as well as proteinuria and the creatinine. So then subsequently he used the ACE inhibitors, ARBs in those group of patients where the GFR is less than 30 ml, and found out that yes, those group of patients also can be benefited. However, if the patient doesn't come for follow-up and you are expecting that the patient is not going to come for follow-up, then it is hazardous. Since I have shown you one that the patient landed up in creatinine level of more than 3 times the baseline level. So the crux is basically when you start the ACE inhibitors and ARBs, start with a very small dose and ask the patient to follow up after 2 weeks or 10 days after. See what is the creatinine and potassium again. Then weekly interval, ask the patient to do the creatinine and potassium. And if the creatinine is less than 1.5 times the baseline and the potassium is less than 5, then you can actually use small dose of ACE inhibitors or ARBs. What is the idea behind that is, it is not the blood pressure control with that, but intraglomerular hypertension will be reduced due to effect over the autoregulation. So that way, if the blood pressure agents you use the other medications like calcium channel blockers, any other beta blockers or alpha blockers, but give a very small dose of ACE inhibitors, ARBs, and closely monitor them. That also will prevent the progression. It is basically the autoregulation, intraglomerular pressure. Sir, regarding another the other question, what is the other question regarding teneligliptin? So renal failure, I think the vildagliptin and teneligliptin can be given if it is the GFR is more than 45 ml per minute. If it reduces below 30 ml GFR, then it is better to use Ondero or similar group of linagliptin instead. Why? Now, linagliptin is basically metabolized by the liver, whereas teneligliptin is predominantly metabolized by 50% by the liver and 50% by the kidneys. And vildagliptin, I think vildagliptin is much more higher. 60 to 70% is metabolized by the kidneys and 30% is by the liver. So it is basically the pharmacokinetics. That's why we are using the linagliptin rather than tinagliptin or vildagliptin. Hello, sir.
Sorry. Can we use protein supplements or can CKD patient
Hello. Sir, your question I could not hear. I think there is
you
some.
heard the question?
No, sir.
Are you getting the question or no?
No, please repeat
Can
it,
the
sir.
patient eat eggs every day? Can the patient eat eggs every day?
Acha. Okay. So it depends upon the actually, it is better to use the biological value, high biological value versus low biological value proteins. So low biological value proteins like the plant-based proteins you can consume, but high biological value proteins like the egg and other things, I recommend, or people, nephrologist community recommend that they should not be every day, since the chances that the patient will go into increased glomerular pressure causing sclerosis of the remaining glomerulus. So that's why the protein recommendation is little bit dicey. We don't have consensus opinion whether few people will say that totally you stop protein, don't take anything. But my recommendation is that there are two ways. That is why I said that if you want to take protein very low, there are few trials in Italy which has been done. Very low protein versus low protein. Low protein is around 0.4 to 0.5, 0.6 grams per kg of body weight. That is the recommended dose for the chronic kidney disease patients so that they should not be in malnutrition. But out of which this 0.6, the high biological value should be around 30 to 40%. The rest will be in low biological value. Whereas if it is a very low protein diet, like 0.3 or 0.2 grams per kg of body weight, then supplement with some other protein which will not cause any urea generation, like this keto
Sir,
analogs.
what about patches? Okay, sorry. Please go ahead.
Keto analogs. Keto
Hello?
analogs are group of proteins or the supplements which doesn't produce urea. So that's why the urea level in your body,
Okay.
in the system, in the blood will be low. So the patient will not be symptomatic. And it has also, in few of the studies in Italy, which has been done extensively, they have seen that with this very low protein diet with replenishment with the keto analogs, they could delay the progression of the kidney disease.
Sir, can we use NSAID patches, diclofenac ketorolac
No,
patches?
sir, no. Actually, that is what a very important point. Sometimes we use, like, if there is a small trauma to our knees or any joints or something like that, rather than taking orally NSAIDs, according to the since the nephrologist has said that not to take any NSAIDs, people tend to apply the Boveran cream over that area. That is NSAID cream. So that gets absorbed through the skin, and that causes also the similar effect. So we have seen people deteriorating in rising the creatinine level with high potassium due to the application of the skin cream itself. So the safest mode of the painkillers will be analgesic will be the paracetamol or opioid group of analgesics, or gabapentin or something like that if it is a neurological pain.
Thank you, sir.
Gabapentin or pregabalin.
Should we avoid calcium phosphorus tablets in CKD?
It depends. If the patient is having hypocalcemia and normal or just little of phosphorus and the calcium phosphorus product is less than 45, then you should be using calcium based phosphate binders. What will be the advantage? And along with that, probably the vitamin D if the PTH level is high. So what is the advantage of that is hypocalcemia is per se detrimental. It can trigger many things. It can cause tetany, it can cause neurological problems, it can cause tachyarrhythmias. All those things can be possible. So we have to control that calcium level. So the recommendation is that you should take the calcium level should be lower than the normal limits. Like you should not be aiming to achieve 9 to 10 milligram percent of calcium. Keep it little bit lower, maybe around say 8 to 9 in that range, so that the parathyroid hormone will get stimulated. It is better to have little bit more parathyroid in your body than just suppressing it by giving vitamin D. Since adynamic bone disease is much more difficult to treat rather than a hyperdynamic bone disease. Hyperdynamic bone disease will not cause much problem unless until it is severe. But adynamic bone disease causes much more difficulty. It tends to go into fracture many times, vertebral fractures, the other long bone fractures are known in those group of patients. So we fear actually adynamic bone disease.
Thank you, sir. Last question.
Hello, sir. You are not audible, sir. Sir, you are not audible. I don't. Sorry about that, sir. I could not hear your question.
How to prevent further worsening, joint as well as kidney?
Means further
How
worsening
to
of
prevent
kidney,
further complication?
further complication of kidney issues. The prevention, no, sir. Hello. Sorry, sir. The renal protection I have already said, sir. But the joint is not a problem. We are basically the problematic one is the CKD MBD, the mineral bone disease. And this mineral bone disease basically with you cannot see in any of the scans. Rather, you have to do sometimes, which is an invasive procedure to know experimentally or in the clinical ground outside in the in outside India, it has been means in the Western countries they do biopsy of the bone to see what is the nature of CKD MBD, whether it is a high turnover bone disease or it is a low turnover bone disease. If it is a low turnover bone disease, then it is a very big issue for us, since whatever calcium through the oral food intake the patient will be getting, that will not be mobilized into the bone itself. It will remain in the vascular structure, in the blood itself. And whenever the calcium will be freely available in the blood, it combines with the phosphorus and causes calcium phosphorus precipitates. And precipitation causes narrowing of the vessels as well as medial vascular calcification, which is the rigid arteries and veins. So that you will see many people, those who are on long-term dialysis, if you do a X-ray also of the hand, you will see clearly what is the arterial structure of that. So it is basically the calcification of the vessels. And when there is a calcification, the blood supply to that area is gone. It is very much compromised. So it causes more tissue damage. It causes more, those people will be at risk for cardiovascular and cerebrovascular disease.
Thank you, sir. Thank you so much. Astani, sir, he is actually out of network, so we can't hear him. But I want to thank you on behalf of him, behalf of Amara, that it was a wonderful session. Thank you for gracing us with your presence, with this presentation. Thank you so much.
Thank you so much. I think the participants were able to imbibe the information what I have given to them. And obviously, without the practitioners will not be able to deliver that to the community itself. And it is a prevention which will be the effective in chronic kidney disease patients. Those patients who are going into CKD stage 5 are maybe around 4 to 5%. But the majority of the chunk of the patient will be in CKD stage 2 to CKD stage 4, where I think the general practitioners will be the best person to manage it. And obviously, early referral, and whenever there is a requirement, you can just talk to us freely and then take the opinion and then accordingly take the guidance and plan it accordingly how to manage the patient. So that is what I wanted to emphasize here. Thank you
Yes,
so much.
Thank you so much, sir. Thank you.
Thank you. Thank you.
Thank you.